Well, once again, good afternoon, everyone. I know you're a bit sleepy, right? Good afternoon, everyone. So we have reached the end of we have reached the 13th panel of this 10th Free Mind long journey of intense content. Maybe we are not capable of being at all the panels, but so it's important to let you know that you will have access to the entire content, not only through video, but also the presentations. The video content is on YouTube at Espírito Free Mind, and the presentations after the event will also be included on the website where you will be able to access all the contact. Oh, Marcela lost some things that they said. So there you will have access to the entire content. So, be calm. Don't worry about that because this panel is very important. So reach this panel with great joy and expectations. The 13th panel of the 10th Congress, Freemind 2025, will talk about women's treatment. Choosing the right treatment can save lives. Now we will see the presentation of some models of treatment available, efficient approaches for women, ways of guiding the families, and also professionals seeking and giving adequate care. The question here, I admit I need treatment, but I don't know where to leave my kids. So what now? That's also a very difficult topic for women that seek for help. I'd like to call to the stage a business manager, a lawyer, and specialized in human rights. He's also acts like a consultant and researcher in public policies and justice with experience on inter-American states in the Reintegreo project, has served as an assessor at the Ipanema project in decentralization between UFF and MDS. He has a professional with broad experience in social insertion, public management, and public policy analysis. Osmar Torres, you're very welcome to the 10th Free Mind. Please, the floor is yours. And with Osmar, I now give you pass you the mic so you can call the other members of the panel. Thank you so much, Marcelo. It's a satisfaction to have this invitation made from Free Minds, sharing space that many times a reference to those who are researchers, and for us that many times are basing ourselves on literature, researching literature. It's an honor to share the stage with these authors. It's a great joy. I work in partnership with the MDS and UF, the Federal University of the State of Rio de Janeiro. And I'm very happy to introduce our panelists today. Each one can please come to the stage as I call you, and also you can make your presentation individually, of course, and it's an honor and a joy to have with us Dr. Giovanni Vargas. He's a professor. Yes, we do get old, that's true. Professor of the nursing school of the Federal University of São Paulo. He's a master and a doctor in psychiatric nursing, also from the University of São Paulo, with a PhD in nursing and addictions by the New York University College of Nursing. And also he's an advisor of postgraduate programs, also at the University of São Paulo, and deal research groups in the area of nursing in addictions and mental health. He's also the president of the Commission of Research and Innovation of USP. Now our next guest, Grazi Santoro. He lives in experience at the end, and she's the idolizer, co-founder of the Association of Women Alcoholism, where she also worked in marketing. She's a therapist in chemical dependency and has been sober for over 17 years. She is part of CONEAD of Minas Gerais State, CT of ABEAD, and also MOVID International and IZUPI. She acts nationally and internationally in the defense of prevention policies for women impacted by alcoholism. I also invite to the stage Mr. Diego Montovanelli, public administrator, public servant since 2008, general coordinator of ZPAD of the Ministry of Social Development, member of the National Policy on the Politics on Drugs since 2025, CONIDE, member of the National Council on Criminal and Prison Policies, master and a specialist in project management, specialist in strategic intelligence, and graduated in social sciences. And also, it's a great satisfaction to introduce to you Dr. Jessica Bolaños. She's an international guest, a psychologist, a master, and a psychopedagogue. She works in dependency, and she's a supervisor of the Integral Clinic of Nueva Vida, and she's consultant of the Association of Therapeutic Communities of Costa Rica, and also of the Latin American Fraternity of Therapeutic Communities. She's also a member and a consultant to CCAD OAS, contributing to the program in terms of treatment and prevention. Please also come on stage, Dr. Bolaños. Our challenge here is gigantic because each has their own living, their own experience, people that are in the top bureaucracy of public management, the ones that are at the end acting in the person's care in their day-to-day. And this is what makes it so comprehension. We have schoolers researching scientifically what is valid, where that will in fact make the difference in the designing of public policy. So with all these different knowledges and visions and experiences, we hope to have the best seminar to all of you this afternoon. So I'd like to invite to begin Dr. Divani Vargas to make your presentation. Please, Dr. Divani. Good afternoon, everyone. I am Divani Vargas. I would like to thank the colleague for his kind presentation. It's an honor, it's a joy to be able to participate in this Freemind Congress. I feel privileged to be here today about what I do and some of what I do, although my field of operation is prevention and primary care toward women in the prevention of use, abusive, and evolution toward dependency. And just to start my introduction, we see that the problem is underestimated. I will divide my presentation into 3 stages. The first one, data from epidemiology. Second part of the presentation is what we do, what it takes, and why it has this phenomena grown so much. Why is it underreported? and the other one is based on the evidence of UN Doc. What do we have as scientific evidence that is most recent for the treatment of these people? So this afternoon, I will bring to you the data on epidemiology and the scientific evidence to this table. Today, I'm a technical advisor of alcohol and other drugs of the State Secretariat of the state of São Paulo, and it was my first insertion, of course, because alcohol, although there are polemics, conflicts, it's girls are starting to use it much earlier on their lives. We're going to discuss all this. What are the needs that this population need? Are they specific needs? And if so, why? If we look at consumption by women in 1983, 32.3% of women in the world consumed alcohol. In 2019, 34.4%, and 2013, the estimate is that the percentage of women consuming alcohol will be the same as men. Here is just an illustration. What happens to men? So LENARD is a national survey on the use of alcohol and drugs. So we had the 2007, 2012, and the 2023 editions. 2023, the last one. And what we see in this table is that men, what happened to them? It reduced in 2012 and it went back, but not at the same level. What about women? The green one. It's growing. So it's phenomena that has increased in Brazil and in the world. The last data from Vigitel, which is the telephone survey that you annually call people to know about their health behaviors, see if they use tobacco, alcohol, how much salt they consume, and other things related to health. Also noticed growth from 2006, the abusive alcohol. What is abusive alcohol consumption? Well, today it is considered to be when the person in only one occasion, like a binge drinking, will drink. The women will drink 4 doses in on one single occasion. So she will drink 4 beer cans in one occasion, men 5. So abusive consumption has increased. So as you can see, from 2006 to 2023, 15% of women now. And if we divide it by age, it's becoming increasingly earlier in life that they're consuming. So the age that consumes the most is the early years of adulthood until they're 34. And the older they are, the less they consume. So we have here, we are saying that the reproductive age is when they consume alcohol the most, the age when they start beginning to get pregnant. So when the woman's going to get pregnant, there's already evidence that if she consumes alcohol, that it will have teratogenic fetal effects in the reproductive glands of the woman, affecting the development of the child. So it's phenomena, as I say, that triggers an issue of public health. So here we see consumption by age again. So in 2006, it was 15.2%. In 2023, 22.2%. Now among teenagers, see how interesting this is. The last ENAD also showed what was happening with the girls. So the boys start from 14 to 17. At the same age, the girls are drinking more than women. They're beginning earlier than the boys and drinking more. So they're overpassing the boys, and that's a worrying inversion because the boys would start first. Now they're starting first. So this early beginning is very worrying, not only regarding physical health, but also regarding the mental health, because it's the brain itself, because it's a phase where the neural consolidation is still happening in teenagers. So there's the urgence for public policies for young adults and teenagers, but mainly directed toward girls. And why do you think consumption grew among women? Why? First of all, industrialization, men go to the job market, greater participation of women, standard in social patterns. So you can go out with your friends and have a drink, as I said, with their friends, with their girlfriends. What does that mean? So, stigma. Men can go alone and take a drink. Women has to go out with their girlfriends. If I see a woman sitting down having a drink, what we will think of it? As I said, stigma. Woman, when she takes on this level, she'll also take ownership of other social spaces, among which the consumption of alcohol. I'm saying alcohol because it's the greatest problem of Brazil in the world. Marketing directed to that. So you see those beautiful bottles, those beautiful cocktails, just like cigarettes, right? The packs full of gender issues. Now you have the pink packs and so on for the female audience. And when it's difficult for us to create public policy, especially targeted toward women, the industry is way ahead of us trying to seek this part of the population. The impact of the pandemic. There's also a study, a partnership of the ministry with Fiocruz and the Federal University of Minas Gerais. During the pandemic, the women increased a lot this consumption, and we see the reflection of this consumption that started at the pandemic, that went on unnoticed, but now are becoming something strong in the public health system. So people that already had some type of health problem have developed a dependency with severe symptoms. I worked in Barretos. Who's from São Paulo State here? Barretos. I worked at the city near Barretos, and I went to the student do research there. All the health units there we used to track for alcohol. Everyone that arrived at the health unit would apply the tools. Do you think the main prevalence of dependence, alcoholic dependence, was seen on who? Men or women? What do you think? The women? Any women? What was the prevalence of alcoholic dependency? The mothers that took children to take vaccine shots. So it's an invisible population. I would pay attention to the mother that takes the child for a vaccine shot. So there are no labels. Probably this woman was such an advanced stage of dependence that no one detected this before, and not even asked her how she drank. And that goes through misinformation. We don't know, health professionals, general population, we don't know how to drink in a safe way, and if there is a safe way to drink or not. So if I drink as a professional health and the other one, then it's okay. I won't ask for two reasons. If I ask first, I don't know what to do with that information, and second, if she says I drink socially, and we ask, do you drink? Yes, I drink socially, because you induce the person, because you don't want to listen that she actually may have a problem. The escape mechanism. So if the pandemics, what happens to a woman? Someone relapsed even more to domestic issues, day-to-day issues, anxiety. No, women went to the pandemic. So pressures, social pressure, gender expectation, generating stigma. So like I told you, what men can drink by themselves at lunch. If you see women today having a drink and men having a drink during lunch, both times, I'm talking about social pressure that women suffer, external validation, seek for social approval due to irreal standards of beauty.
And among the girls, to be part of the group, you have to drink because among the group, among the peers, there's pressure as well. And social isolation. What happens? Because of that, women cannot go to the health system because due to stigma, she has a difficulty to access that service and to reveal that she consumes it and she wants help. So That's why I say that no, we have to pay attention to all women. We cannot lose any women. So, vulnerabilities and risk factors of the women's population. Women are more vulnerable to the effects of alcohol. They develop the disorder earlier. Psychological factors. They use alcohol, not that men don't. They stay at home most time and they use alone due to stigma, and when you notice the case is very severe. And the social barrier of the perception that women have that women should not consume. So the telescopy phenomenon, the telescopy is a phenomenon that even in small doses, they develop these harms much faster and earlier. So different metabolization, type of permanence, bodily composition. Alcohol stays longer in the women's bodies. And here is mortality among women due to the use of alcohol. So we had 105 deaths in 2022. 7.5% were women, and among men that reduced the mortality reduced in 88%. And who are the women who are dying here? Now keep this in mind. Who are dying? Black women who are heads of their families. And this reveals the impact of the inequality, on the use of alcohol. So it's an inequality of access and of treatment. And among them, the social issue is another vulnerability. Here, women is much proner to develop cirrhosis. It's threefold the risk of her developing it. Pregnancy and breastfeeding, they're compromised. Increased risk of cancer. Fetal alcoholic syndrome. In the last month, 107 babies in the state of São Paulo were in the neonatal intensive care unit because to that. In other words, no one asked during prenatal exams, no one asked that those women if they used alcohol. Of course, São Paulo is a big city, but it's a lot still. So mental illnesses, the woman is depressed and she's anxious and she drinks to alleviate these feelings, and then she develops an abusive behavior. Chemical dependency, there is a difficulty in access to treatment because if among all people in the world who have a disorder in the use of alcohol, one out of six receive treatment. If we go to illegal drugs, one out of five, maybe due to the impact and due to the noise that makes using crack and opioids. And alcohol is usually silenced. And mostly they are together, hand in hand. And these statistics reveal a significant access barrier. Among women, this barrier has different aspects and complex aspects because they have multiple difficulties to seek treatment. And these barriers, and know that there's a huge difference between one audience and the other, is the key to develop effective actions aimed at that population. So you have social stigma, family responsibilities. How can women seek treatment if she has to take care of their house, of their children? How does she arrive and when does she arrive? Insecurity and trauma, history of violence and abuse, lack of specific programs. And then all of that leads to what? If the general population among men, 1 out of 6, among women, 1 out of 18 women who have a disorder due to the use of substance access treatment. That's what I say. If anyone comes out to you, reaches out to you, you cannot lose that woman because she will not come back. She will come back to die. This is published in the Addiction Journal, a partnership between ISUP and UNDOC. So access rate 1 to into out of 18, specific programs for women, 3 program out of 10. 83% mixed installations for men and women, and 8% had exclusive programs for women. One, are these two women the same? Are they equal? Are they equal? They are women, right? I used to work with this population. And then, how do you get back? And then I went up to see in the last 3 years I'm working with them, and it's very, very different. What I'm telling you that 1 out of 18 women have access. These ones are having more access than these ones. So you have to think of that as well. Social vulnerability to which women are exposed. So and these here are two times more exposed, and there are very sides of this consumption. So what are the best recommendations for women's treatment? Gender expansive programs, that's the basis for success, even in groups. It's no use of men wanting to do groups with women. It won't work. The peers among them, it's when they are among themselves, it's much easier. They feel more at ease. Why? Due to stigma. Of course, after a while, after you establish a relationship, you have contact, it's fine, okay. But in the beginning, it's about them. I can go there, study, and participate from time to time, but things actually happen among them. So then, trained, multi-professional team, safe and welcoming environments, welcoming without judgment, intake without judgment, and adapted services. Here, support for efficient psychosocial approaches. Remember that mom with children, think about these issues. We want women to be there at a time where they're available. So that's it. Thank you very much. Thank you, Dr. Edvine, for your presentation. Our time is being very well controlled. Now I will invite Dr. Grazi Santoro. Grazi, please, you have the floor. A round of applause. Good afternoon, everyone. My name is Grazi, as I like to introduce myself. I am a woman with disorder due to the use of alcohol. I am a survivor of violence, of different types of violence, and as a survivor while under the effect of alcohol. I'm glad that I survived to be here today. This question, I admit that I need treatment, but I don't know where to leave my kid. I started to think, I even talked with my workmates. If it were a man, let's think. If it were a man, would he say that I admit I need treatment, but I don't know with whom I will leave my kids? No, he wouldn't. He has a wife, right? He has his mother, he has his aunt, the entire family to take care of his child for him because he needs treatment. But women, when she can verbalize, when she can express that she needs help, her own mother condemns her, judges her. Her own mother does that. You're going to lose your husband. Are you crazy? What about her children? It's what doctor just said about the stigma. Women were raised to be mothers and take care of the house. They cannot get sick. they cannot get treatment. Let me get the ticker. So the first thing I started to think, who are the Brazilian mothers? First of all, out of 10 Brazilian women, 7 are mothers. Out of these 7 mothers, 4 Brazilian mothers are single mothers. There are no fathers. There were sperm donors, but no fathers. They are single mothers. Out of these 4 single mothers, 3 are black and have no relative or support network. I got the goosebumps by saying that. And out of the 4 single mothers, 2 are unemployed and in poverty. This is the source. You will have access to the presentations, so I will not say from where I got those, what's my source. And how many Brazilian women with disorder due to substance abuse, they are not addicted, okay, you guys, please. They are women who are sick with a behavior and mental disorder due to the use of alcohol or other drugs. The stigma starts in the words we use. And then repeating what doctor said, 1 out of 10, out of 18 women seek help, seek treatment. Whereas among men, it's that rate is 1 out of 7. And who are these women who seek help? That one woman who seek help, most of them are mothers. So who are these Brazilian women who suffer from disorder due to use of alcohol or other substances? They are women marked by suffering. I will read here. Okay. Most of them are mothers. I've already said that. Lonely mothers who are exhausted, overloaded, and sick. They suffer with racism. They suffer violences, abusive relationships, sexual exploitation, family abandonment. They don't have a support network, extreme social vulnerability, and many of them are in a homelessness situation. Some, okay, I put 4 over there. So they are distant from health institutions. They find it difficulty to leave their kids somewhere. They don't know where to leave them. They are embarrassed in fear of judgment, and they have difficulty to trust professionals.
Now I will talk a bit. Now I talk about the actions to reduce inequalities in health and strengthening of justice and the right to health of women with disorder for the use of substance or alcohol in vulnerability under vulnerability. Treatment for this woman is only sustainable when there is articulation among other sectors. So it's good that Diego is here. So yes, so health to ensure the monitoring of their clinical conditions, sexual and family health for the woman and her children, social assistance to guarantee access to basic rights and social protection, education and work to allow for them to go back to study and become independent financially, intellectually, justice to have humanized intake if necessary in needs of situation, and many of them fear losing their children and because of that do not seek treatment, so have some sort of support in this sense. culture and living to expand circulation spaces, create bonds, and reconstruct social support networks that have been broken. We talked about racism, and it's very important that professionals, and I know several professionals, know how to recognize that racism does impact in a very striking way access to all public and private sectors, and consequently the quality of life of black women. Understanding these issues is essential to promote an approach and a practice that is anti-racist in all areas, including health. So here we suggest a course of uh, be, becoming literate in racism for professionals so an anti-racist course. It's a certified course, a course that grants certification by a renowned institution. So it's important that all workers in their area undertake this course. And in our association, it's mandatory, so it's important to transform practices, supports to different types of motherhoods. There is no motherhood, there is no treatment for the mothers without the support to the several types of motherhood. We saw that at the beginning of my presentation. Specific groups with topics such as violence, health, sexuality, listening and affection workshops, how to deal and cope with racism, sexism, transphobia in the services, cares and intakes that consider the historical, social, and psychic conditions of the women. We need to also have that into consideration. What helps deal with a woman with TUS? So to be available, non-judgmental. I think you all agree that. TUS being disorder from the use of substances, and seeing the woman beyond the user identity, not being prejudicial against her story or way of living, showing her that she deserves to be there and that you really care about her. Be careful with the words, even when you need to call her attention for something. Ensure that your conversation with her will be confidential, encourage independence, and help deal with new strategies to deal with problems and make real changes of environment, routine, relationships. In fact, helping access resources such as medications, documents, and other opportunities. Now I'll be quick because I only have 6 minutes left. I'll be quick in showing you how we work. Is it like those shady organizations? All your problems, I'm the source for all your problems. Not really, right? We created a model for the treatment and recovery that is virtual, online. So first thing, all these women that you see here in this map, I said this yesterday, are women from our association that left anonymity to say, hey, I have a disorder from the use of alcohol and I'm not ashamed of it. I'm there. Flavinia is there also. The other, all these women are women from our association. And the sentence that we say, all these women, is let us love you while you're not able to. That's our motto. Thank you. Thank you. I'm even trembling. We're an association without a non-profit organization that take humanly women that are suffering in a scientific based and human without judgment and prejudices. Our values is humanized intake, empathy, and respect, and we have been existing for nearly 6 years. We're quite young yet as an organization. We have taken in a human way women from Brazil, women from Portugal, Angola, and other places of the world, and that's how we work. That's how we work till this date, because this association was built in these 5 years by several women. And another slogan we have is I am because we are. Everything we have built was built by alcoholists and under recovery women. And here I have Flavia, the psychologist, Raquel, Eugenia, Jana, who are women from our association. And I'm only here because they're with me and because they believe in what we do. We have this is all online, okay? All online. So, for example, you have an organization. Oh, Graz, we want to participate with our organization. Okay, you put your intake women in a space, put internet, television, and online. They will participate of all our activities for free. Okay. We have 12 therapies in group, and we work emotional dependency, prevention from relapses, well-being and health, sexuality losses and grief, motivational cycle, and alcoholic progression. Raquel is responsible for the sexuality. She's a psychologist and sexologist. She conducts this group, specific group. We have a group only for women that suffer violence. We have Speak Out for non that is only for non-white women. We have an empowering group, a motherhood group, women that have just arrived at the association, a group only for women that arrived, that have just arrived at the association. And next year we'll create a group for spirituality and young adult women. So it's over 50 professionals working for that to happen. 11, sorry, more than 11 professionals and over 50 volunteers. Health volunteers under recovery through our methodology. And we have something that we call troca, exchange. What is exchange? The time of we reserve. What is T from time? Reserved R to look O and care C for me A. And we need this time to look for us, to look at ourselves. And that's when we have these meetings called trocas. Now, my periodical meetings at the end of the year, we'll do a strategic planning for 2026 with Claudia, who's one of the founders, and so am I. So we work with GPS, so we never get lost. No, just joking, but we know our way back. So, what is the guide for sobriety? These are coordinates for to have a good life in sobriety, because it's not like, oh, I'm going to stop drinking, so I'll be sad and happy. I'm happy sober. We will have these women have independence, self-esteem, and to be able to be happy without using any type of substance. Of course, sometimes you get sad because she has to reconstruct a life, but life without alcohol is very good. Alcohol without any type of drug is very good. Who is a chemical dependent here needs to leave anonymity and take this message on, because lots of people are suffering. So we have coordinates, 13 coordinates, all based on science, so these women can go to the psychiatrist. Something important. I think my time is running out, right? Yeah, okay, I'll conclude. Um, our doctor here said, oh, the doses due to the United Nations is 4, and for men is 5. What if you underwent bariatric surgery? Is that a standard dose? No, it's not. We need to look at that also. You know how many women in our association, of the 400 we have today and have intaken across Brazil, do you know how many underwent bariatric surgery? 35%. This is really really worrying, really, really severe. So, of 100,000 surgeries carried out in Brazil, that's the average every year. 75,000 on women. And of these women, they are at the risk, a very high risk of becoming alcohol dependent. And do you know who says that to them? No doctor at all tell them that. No doctor will tell her that. Look, do you have a history in your family? They won't ask. If you make the use of alcohol, how many doses do you drink? They don't ask her. And then they say, you stay 6 months without drinking, then you're free to drink. Yeah, right? So I know that. How many people here know women that did this surgery and that are alcoholics? Many of them, you, right? See, yeah, yeah. Lots of women becoming alcohol dependent in 2030 is still too far away. To me, it's already happening. We are already overpassing men in this sense. I'm going to conclude. So I'd just like to say that we have an anti-racist work also in our association. I talked a bit about that, and I'd like to read this end, okay, very quickly. All of us in our operation, in our spaces of acting, can contribute to construct a network of care that is fairer and more humanized for a woman with needs related to the use of substances. All of us here. Strengthen this network means recognizing women as mothers, workers, caretakers, and the subject to rights and guaranteeing of having real conditions to move on. In this context, taking care of is much more than a professional task. It's a political gesture, ethical gesture, and profoundly humane. Thank you very much. Thank you so much. Amazing, amazing. I would say that was impacted and very happy to know that there is this work. And not only because of the work itself, but knowing there are qualified people that are able to not only do that, but have a great reading of what they're doing, of their own work, because knowing where your steps are going is called methodology. So you can replicate and pass on to other people. And then with the methodology, that is much easier. And I'm learning a lot. So now I'd like to call to the stage for the next presentation Diego Mantovani. He's a public servant to the federal government. Diego, the floor is yours. Welcome. This is the order they gave me. Well, can you start counting time only after I congratulate everyone? So good afternoon, everyone. Are you all awake after lunch?
Let me here go under the light. First of all, I'm very happy to be part of this event, which has such a great expression in our country and abroad. So I'd like to thank Freemind for inviting me to share knowledge with you in this event. I'd like to thank Samuel and Paulo and the entire Freemind team. Sami as well, the director of the pod, and everything I've been learning with the DPOD team. I'd like to thank the presence of all associations, federations, federal councils, city councils, and all professionals we are having contact with. But mainly, I'd like to give a message to all peoples who have been catered to by the social development ministry. You are the target audience of our work every day. It's a challenge to come here and speak after Graziella because I'm an apprentice. I'm learning. I've been learning every day. I think it's very little we are doing in view of the all the need that we have here around. But I believe that I can contribute a little bit to save lives. So that's the goal of our work. I'd like to talk. I will talk about technical issues now, but I always begin by saying that we are talking about lives. So let's start. I'd like to do a quick recap about this theme, and this history is important. In 2024, there was the International Conference of the International Confederation of the Therapeutic Communities. FEDON is here as well. We have been establishing a close dialogue, and we know we're going to make progress in our dialogue. Thank you, FEDON, because that event inspired what I'm going to say now. And in that event, I'd like to say that Jessica inspired of what I'm going to say, talk about here as well, and Yara as well. Samya and I, we watched Jessica's lecture and Yara's lecture, and that motivated us and inspired us to work with this team, women's humanized intake, because we know there's a real demand and we must focus on women's humanized intake. Later, we talked with the Ministry of Women at the time. Right after that event, Dr. Eli is here as well. She was part of the Ministry of Women. I'd like to thank Eli. She also inspired us in this work. And she encouraged this dialogue in the Ministry of Women. And based on that, we drafted an intention protocol so that we can deepen studies about women's increasing need regarding drug policies. And based on that, Dr. Eli is here again representing Unicamp. We contacted USP through Professor Gustavo Riga, Marcos Alvarez, and the International Federal Institute of Mato Grosso do Sul, which helped us coordinate a work whose result was this international seminar about women's humanized intake with women with SUD. Graziella was there as well. She supported our event. So what I'm going to tell you here today is very much related to the history I'm talking about. So who am I to talk in the name of women? I'm only the spokesperson of everything women have produced, especially in this event, and I will present a few results. So before talking about the seminar, I'd like to talk about a research conducted by our department. Whoever wants to see it, it's in the QR code. It was made by Department of Entities that support humanized intake on alcohol and drugs. So in this study, there were over 3,000, almost 3,000 people that were surveyed. This is about our contracted vacancies, our vacancies contracted by the Ministry of Social Development. So in this context here, we have basically less than 20% of our vacancies, hired vacancies, reach the the female audience. However, I'd like to point out that this occurs even when in our public calls there is a preference of women who are breastfeeding and women in general. However, the amount of vacancies is no higher than 20%. We contacted all organizations that work with with women, and the result was the same. So this is the current scenario. In our study conducted by Judalias, a little bit more than 23% of vacancies were surveyed by this study. So I will move forward. Otherwise, I won't be able to talk. This is the racial profile of the people that we receive in our entity. So most part of our audience are black women, and black women in general, so in our entities. A little bit more than 20% of these women had prison history, either being convicted or not. So this shows the relationship between drugs and imprisonment. And here, one of the main barriers to seek help, and these were answered by our people who are cared for in our organization. So both genders believe it's difficult for them to accept they need help. This happens in both genders. Second reason, lack of help or support or motivation to seek help. You can see that and 12% of this barrier is among the female audience. Very often, the family itself is a barrier that prevents women from seeking help. And lack of access to information or lack of access to the service. So we held this seminar we faced many barriers, but we did it. On October 6th and 7th, Graziella, Elias, they participated. Many people who are here were there in the seminar. And the idea was to hear experts in the field, hear people who work with humanized intake to understand the main challenges. And based on that, work as a ministry. After listening with the help of these agents, the idea is to produce a public policies that is more efficient to cater to these women. So I'm highlighting the Federal Institute of Mato Grosso do Sul. Unfortunately, Professor Jayza could not be here, but the work was organized by her. So the seminar was conducted. We heard professionals from the entities as well, and based on that, some guidelines were established so that later we can have an in-depth study and improve our public policy. Professor Jayza shared with us, and this is only a summary of this work in progress. So we heard these professionals, and in view of that demand, we separated topics so that we could establish guidelines, which were these themed categories. Everybody's there, right? Everybody's following me? Great. Most women, we have the majority of the audience are women, right? The female audience is present, is winning. Great. So let's proceed. So let's talk about the institutional structure and protocols, humanized intake practices, vulnerability and harm reduction, intersectoral coordination, efficiency of approaches, family, social reinsertion and funding, evaluation of results and public policies. So I'm going to talk a little bit about each one of these things, which were the main findings. About structure, our main focus regarding therapeutic communities is the focus of our work in MDS. The main gaps and problems that were identified, lack of well-structured protocols and aimed at the female audience, lack of quality and certification instruments to standardize these processes for women. It was also pointed out that the approach of women's humanized intake must be centered on trauma, not guided by trauma. The need to have protocols, including quality and certification instruments who follows our work. I say that it's no use saying that my cake is the best in the world if there's no criteria. If all of you do not taste and we have the final result of how good is my cake, I cannot say that my cake is the best one in the world. So we need instruments to verify the quality of the service I provide, especially of those who tasted my cake. because those who haven't tasted cannot say if it's good or not. Then some recommendations. The creation of a commission to outline strategies to better offer humanized intake to women, strategies for continuous training, which Graziella mentioned. We must train teams to deal with the specific audience, which is women. Demands are different. The men's demand and women's demand are different, and they must be treated differently. That's why our professionals must be trained to address properly. If you have a son and a daughter, are you going to treat them right the same way? No. So we have to treat them differently. So national guidance on protocols to cater to women with SUD and training of professionals. In addition, coordinate with the network service of the Justice Department. I recall a testimony of a woman who went through humanized intake, and she said, Diego, I took years to talk again and with my children, and much of that because of my difficulty to have access to justice, and this moved me a lot, and that topic was also addressed in that seminar. So we must make feasible the access to justice for that woman, because in addition to suffering violence, she's forced to stay away from her children, and she loses the guardianship of their children, and then she comes back to society. Where are my children? And she suffers with her past, and it's difficult to get back to her family, to truly get back to her family. So it's an aspect in which we must improve. Now, related to cultural issues, so humanized intake strategies aligned with cultural issues, so indigenous women's, and even among regions. Here we have the same accent here in Rio de Janeiro. Do you think the women from Rio de Janeiro are like the northeastern women and women from the south women? We are a huge country, and our regions are very much different, and people from those regions are very much different. So let's move on. Now it will get harder. I'm talking in front of my boss here. So humanized intake practices. Stigma, lack of services, gender-based services, lack of testing for sexually transmitted disease. So we need protocols to have these women from the start tested for diseases. It's very important. We must make progress on that. Recommendations, we spoke about that. Training to break with the cycle of violence, so that woman suffers violence, she suffers from disorder, and she's reinserted, but she does not know how to deal with that.
So we need to also train women so that they do not go back to the cycle of violence, because we treat only the disorder for the use of due to the use of substance, but we do not treat her ability to treat this cycle of violence. Also sectorial interaction. I wanted 15 minutes plus, but Samuel is looking at me, so no can do. I spoke in the morning at the National Forum of Councils, and I was invited to speak there. Articulation is needed to make intersectorial articulation come into force is very hard. I mean, I like saying, fortunately, we live in aisles, and this should not happen. Articulation needs to take place. Family reinsertion and funding. So work with the family is crucial. We know that women suffer stigma much more from her own family. I will talk about this. This is interesting. We need to overcome the rationale of applying equal ingredients to everyone and consider the individuality and the history of each woman. flexibilizing rules. Also, in therapeutic communities, each individual is a single individual, so the rules need to be flexibilized according to the need of each individual. So, assessment and results, as I said, public policies, you need to monitor the results. You need to know if the person that went through your service, this woman, in fact, was impacted by your service across time. So defining indicators not of only of about abstinence, but to know if in fact the life of this woman improved after she was taken into treatment regarding health, work, social, and family reinsertion. All of this needs to be assessed, measured. So we need efficient mechanisms for that. I liked leaving this message at the end. Uh, Treated women, you are the target of our daily work. This is our effort. We still have a lot to do, but this is our effort, and we have not ended yet. These were findings of all these professionals, specialists. We have people from the University of São Paulo who took part in the event. Jessica was there. So we are seeking these type of knowledges to deepen our public policies. So once again, thank you, and I'd like to leave my contact with you. Thank you for all of you being present, and we help to overcome even more these difficulties. And with the effort and hard work of everyone, we know we can advance. Thank you, and have a great afternoon. So guys, we're in a space and we are constructing public policy, and this is done through dialogue. Dialogue with different visions, different looks, and that is why we have brought someone with a look that is very different from other realities, but might have some similarities, but there also might be differences. So Jessica, please, if you come to the stage, the floor is yours. Come add to our discussion. Well, good afternoon, everyone. To me, it's a pleasure to be in this Freemind, in this 10th Freemind, which is in fact a space, a bridge of knowledge and hope for all the people here. I have a hard task, which is to talk after these three great panelists. But I'm going to talk a bit about the seminar that Diego mentioned. Some data will show up here again, but I think it's very important to know with clarity these data. And thank you for Freemind for this space. For the second time, it's a space exclusively for treatment for women, because these women are voices that have been shut up, and this Congress in several ways emphasizing these voices that we many times do not notice. So thank you so much for this space. Now we're going to talk about the receptive treatment for women that suffer trauma. And as Diego said, when we speak about women, we talk about women that are users. We cannot forget about the trauma they had. Trauma is a topic that is new, but we need to be open to offer treatment informed by trauma or receptive to trauma. And I'm going to tell you a story. At the age of 18, she learned how to wake up very slowly so she wouldn't wake up her father who was drunk, and they told her to keep quiet. What happened in the house should not be mentioned outside. Silence became heavier than the screams. She grew up with fear and a knot in her throat. 12, she started having anxiety and using marijuana. At 16, she discovered that alcohol and also pills also reduced her internal noise. At the age of 20, he had gone through clinics. She never spoke of her fear. They only asked her why she used these substances. And this account shows two things: that many of these women that use and we serve have grown up in an environment where stress, anxiety, and trauma are part of their day to day. And when they don't have, figures that will be a source of control, of contention, it's quite often that the use of substances and abuse of substances will emerge. We know that you also know these similar stories. I'm going to show a document review, but I also bring here the voice of the women that we serve in our clinic. I'll speak very briefly about the data. On the last report on the use of drugs says that 360 million people use drugs in 2023. 1 out of 3 users is a woman. And what is the gap here? 1 out of 3 users are women, but only 1 out of 18 women are treated. So there we have several women that are not having access to treatment when compared to the 1 out of 7 of men. What's happening? Well, the woman faces so many obstacles. We have an article publication that says that we women have specific needs, specific demand, and we need different treatments with individual treatment, specialized treatment, with family monitoring. Monitoring is very important for women, the monitoring by their families, and that close people to them know what's happening. She cannot be isolated. Another thing that it also mentioned, our colleague, the telescoping, he explained women start using later in life, but when they start and they seek for treatment, they are worse clinically, because even using the same amount and at the same frequency, they show greater vulnerability. So the first use leading to the disorder due to the use of substance, the time is shorter than men, and we have to take that into consideration. So we need that treatment for women is gender focused, and that understands and accepts that there is trauma. Here we have some obstacles, personal, interpersonal obstacles, because we know they have several conflicts with mental health, disorders, social cultural problems, discrimination, and stigma, and of course also structural and systemic obstacles. We rarely have treatment for women, so the availability is minimum, and the ones that actually exist, there's a long waiting list, and possibly they don't have a support group, while women wait for access such treatment. And we have no care regarding the children. Who's going to take care of my child so I can seek treatment? What we do have are programs that were designed and we adapt to them for women. Other are programs that with mixed attention, and we know that is not what we need. We need spaces that are just for women, specific for women. Let's go to trauma now. We have an author here that speaks about trauma. It says that all addictions are born from a wound, because when a person is connected to oneself, won't need to destruct oneself to alleviate pain. So there's a lack of internal connection, and trauma usually is the root of the use of the consumption. So we see that when we have trauma, the emergence of disorder by the use of substances happen, and this disorder makes her exposed to makes the woman become more exposed to greater violent situations, more poverty. So traumatic situations come with this, which means that trauma and SUD are they walk along, and one makes the other grow and vice versa, and this makes it all much more complex. Let's look at the concept of trauma very quickly. But when we talk of trauma, we have three E's. It's an event that is experienced and that has effects. It's an event. When we say an event, it can be a single event or a set of events, a repeated event, an event in series. When we talk about experience of the person, it's as almost as a threat. She feels that the resources she had are not enough to face that experience, and that threats her psychological, social, and family, economic stability, among others. And in a way or the other, will affect her well-being, right? And for the future. When we think of trauma, we think of an accident, we think of sexual abuse, but we have to be more specific and say, do we have traumas? Do we have intense traumas? It can be an accident, of course, but there are chronic trauma, like living under chronic stress, woman that lives under domestic violence, and the complex trauma, the one established from 0 to 5 years of age, and this is where it is produced. People that should take care of us and protect us were not able to, so the person grows up feeling threatened all the time. Numbers of trauma: 75% of women under treatment for SUDs have say they experience at least one traumatic incident in their lives. People that had physical or sexual abuse present a probability of 73 to 74% of developing a disorder for the use of substances. And a study in Latin America says that 71% approximately have lived at least one traumatic event in their lives. What we see here is a research from the 1990s where they assessed the situations these children lived, and they classified 10 items. Three physical, sexual, or psychological assault, physical negligence, for example, where there's lack of food, or clothes is not clean, or emotional negligence, and also family instability, which can be, for example, growing up with a family member with some mental problem, physical problem that is chronic, that does not allow for this person to take care of the child, someone in prison, a divorce, an abrupt divorce. But what's interesting here from this research is that the more adverse the situations in childhood, the greater the chances of acquiring a disorder for the use of substances. We cannot talk about violence and gender without presenting such data. Usually in life, children have the same possibilities of having some type of aggression. Regarding the boys, it's probably more physical aggression, and girls sexual aggression. But in teenage years, in adulthood, and we see that men are more exposed to having situations of violence and trauma by women that do not part of their lives. Can be a crime, someone that are not within their group, and their colleagues.
But among women, the risk in teenage years up to the adult age of suffering violence is violence from people who are close to them, with whom they have a relationship. People who tell her, I love you. And what we see among these women who come for treatment, if I get close to them, they think I can harm them. So we see that a lot among those women with we work. So how can we give treatment without addressing the trauma? Having a trauma, it's like having a bag full of stones and having to carry it the entire day. And usually, what happens during treatment? We ask and we judge, and we don't ask why that person is like that, what they carry in that. It's like we are wearing a blue colored lens and we see the same experiences, the same color always. And when we talk about programs that are effective regarding trauma, is programs where we understand that 90% of the behaviors of women are related to their trauma, and what we must have clear in trauma responsive programs. We have to be in our previous programs. We sought abstinence, and the rest would come later. But the research shows the opposite. If we work trauma, we will have an improvement on SUD. But if you work the disorder without understanding the trauma, with time there will be an unbalance which will cause relapse. What these programs aim at: culture of safety, physical safety, psychological safety, social safety, and moral safety. What does that mean? Having a space only for women. It means that everyone, absolutely everyone who works in the program must know the trauma from the first person who welcomes them. And let's think a little bit in the physical part. Let's think. What does it mean in a dark alley that goes from the bathroom to the room for a person who suffered some type of sexual abuse? That may be a trigger. That's why in these trauma responsive programs, the physical part is very important. So when we get to a place, we have 7 seconds to understand if you want to stay there or leave. So I ask you, who are undergoing treatment, what people see when they get there? And the person then gives a very good example. There are so many things we can do in our physical space, such as color, lighting, posters. And it's difficult very different. And it's different when we see, oh, here we end with denial. Why? Because we're always talking about negative things. These programs must work based on strengths. So the correct thing would be to say here hope starts. So how are our programs doing? What are they saying? Let's think about their physical aspect. So is their physical safety okay? Do people feel safe and not exposed? It's important that all people working in the program, they feel well. No, now my time is ending and my colleague will be standing and I'll pretend I'm not seeing him. So regarding physical safety, people, when they suffer abuse, they do not know how to set boundaries, or they tend to be very close to people or far from people, because when someone has been exposed to difficulties and they don't trust anyone, what they think is that if I get too close, you can harm me. So physical safety is about ensuring that. Psychological safety is how we teach them to feel well being themselves. Psychological safety is a treatment plan. Which are the parts that are missing? Self control, self efficiency, feeling that they can do things, they are able to do things, They can handle things, emotional regulation, etc. But psychological safety must come from those who work there. Social safety is learning how to feel at ease with my companions, my comrades. Is knowing that there will be no aggression in that place, and also sense of belonging, teaching how to have a conversation, an argument, discussion. They do not have to isolate themselves. They can be there. But the culture of safety is what makes them believe that they can stay in that place. And of course, moral safety, which has a lot to do with what we do, with our personal value, institutional values. Lastly, and to end, to wrap up, thank you very much from the bottom of my heart. I'm so grateful for being here. And time is very short, but this is a theme that it is worth approaching, addressing, readdressing, and understand that the seed that's more difficult to make them getting into treatment, but when they start treatment, they have a better performance, and prognosis is better than with among men. Thank you. Is someone taking care of the time? No. Okay. That should be my role. You guys, we will open to 4 questions, but we have 1 minute to ask the question and 2 to 3 minutes for the answer. So we're open for questions. Who would like to ask Dr. Eli, please? Hello, good afternoon. First of all, I'd like to congratulate you for the brilliant lectures, for your experiences, and for the knowledge you shared. I'd like to ask a question to Diego about this trajectory, this journey, this survey, and the developments of all that was produced. And I'd like to offer a brief context about the little I know about therapeutic communities and how I perceive them. As Diego said, I was heading a, a department in the Department of Women, and the department asked us to have a partnership to make a diagnosis based on which we could think about guidelines, establish protocols to improve these services aimed at women. And I can say that it was an interesting experience because I started to observe the dispute established within the different fields of knowledge within the federal government, the resistances, and also a dispute for knowledge and how to address the theme among health, social work, and so on and so forth. So we are here. But what I noticed together with the MDS was to intend to improve knowledge, seeking that discussion to the scientific field, and to establish guidelines and move forward with the agenda to improve, never to deny or resist surveillance. On the contrary, so based on everything that has been produced, based on your perception in this field, and these rich discussions, how do you evaluate that based on this final diagnosis that you are establishing together with Mato Grosso do Sul Federal Institute, which are the possible decisions and actions do you believe it can be possible to improve the service to help women? And I also ask the same question to Dr. Samuel. Thank you very much, Dr. Eli, for your question. Our minister, Wellington Dias, he has always said, I want you to bring science to public policy. Right. So since the beginning of our management, that's what we have been doing. And we can say that in 2023-24, we conducted the biggest survey in Brazil about therapeutic communities. Over 500 entities visited by a federal university. The medicine faculty in the University of Minas Gerais has conducted this biggest survey in Brazil. And that was conducted with independence because we do not want to deny or to affirm. We want science to tell us. And of course, listening those who are experienced. So entering to the women's issue specifically, the idea of this event is to address this demand and see what can improve. And based on that seminar, we had those guidelines that were indicated. And what's the result of that? As I tried to say, in addition to the seminar, we listened to people, even Professor Geisa, also heard professionals and patients in care. We also heard Graziela's association. With SAMI's authorization, it's very important to hear, listen to Graziela's association so that we can have an in-depth study to generate improvement in our contract and also general rules for the entities for them to have cater to women in the best way possible. That's what you want. We want science to guide us to the best way. Here, listening to the patients in care, listening to workers, because it's fundamental to hear all of the agents involved. In short, Dr. Lee, that's our intention. Next question. Anybody wants to ask a question? 1 minute for your question, please. Thank you, Osma. Thank you, everyone, all speakers. My question is to Professor Jessica. Jessica, yes. And a question to to Grazi. It's very interesting the approach of your work, your methodology of recovery, of offering treatment. And I'd like to know, it's a very simple question about access. If we, how would it be, what to do to have access to your methodology and to know about other results of our work, and to Grazi as well, not Professor Grazi, about that issue of access. How can we have more articles and more information about your online course? If you do lives, maybe that they are open to the public. Thank you. Well, thank you very much for your question. I'd like to say that this expose, it's a review of documents from the main authors that address trauma, and also the WISE program with CICAG, Organization of American States. And when we talk about a program that is trauma responsive, I'm using the Coventony Bloom methodology. It's a program that talks about how to become a program informed by trauma and responsive to trauma. It's a program that can be researched. I can send through the contact through Freemind and share it because it can be read. It's beautiful, and actually it's a program that has 12 sessions in which each day there's a training from institutional culture until the practice of people who are there can be a trauma responsive program. There is the version for men and women, and we can get in touch and make this information available for you. That's what is Freemind. Help people help others. So let's meet this goal. I am at your disposal to offer this material.
You can access our website, associationaf.org. It's also in the material. If you put on Google feminine alcoholism, we are the first organization that will appear on Google about feminine alcoholism in Brazil. So our website is available. We also have an Instagram, alcoholismo feminino, and I can provide my private contact, my personal contact, if you want, so we can create partnerships and help more people, help more women. Please really count on that. So now, one more question. If there are no other questions, I will ask a question to Dr. Divani. In your experience in the state of São Paulo, I would like to know what would be the great challenge that needs to be overcome yet. São Paulo state and is seen by many as a more advanced, more successful state in several public policies. I'm not saying it is an example because, as Dr. Diego said, there isn't only one way of doing it. So it might be very good there, and they might work or not. We are learning. So within this policy, based on your broad experience, I've been looking at your resume before coming here. It's so comprehensive. What is the great challenge that needs to be overcome? Thank you for the question. It's very important and interesting. The greatest challenge is to guarantee access and rights in equality to women also. We are establishing in São Paulo state lines of care. We started with the open use scene because that's where the demand was more predominant. And we're also establishing a line of care for women specifically, thinking of all the matters about the specificities, the difficulty of access, and the training and skills of the professional for the screening and identification early on, and for those who are already ill. What are the paths and the intersectorial concern for when she comes back, she's able to desintoxicate. If that woman that was able to do it, what happens to this woman that was able to do it when she comes back home? That's the main topic. And that's a perspective we work on also, offering access to these women. And regarding social development programs specific to women, we have therapeutic houses for women, and women in their diverse comprehension understanding of a woman is trans and so on. So the next line of care is very specific for women. So guarantee access and most of all the exit door, which is a challenge for men, but even more challenging for women because of the issues that Gracie mentioned. When a woman exits a program or a recovery, she still suffer the violence. So that is a guarantee of access to enter as early as possible, be identified as early as possible, and those that could not be helped before entering dependence, when they leave dependence, the one out of 18, we will offer her all the support as a public power. I would like to add to what he said. A large part of what this response for this monitoring that is so important, because for us, no, it's not just a chronic disorder. It's what happened after the treatment. Definitely is crucial. We need networks, support networks, but many of the answers are in a new paradigm of recovery, which is what is being put in place now, and that allow us to be trained to understand how this monitoring happens after treatment. I would like to thank the attendance of everyone, and I'm very happy we moved forward today. One step only. We know the journey is long, and we know know little of women's universe and that we have to learn much more. So we listen to women talking about women, men talking about women, and all this makes us be very grateful for this time and space. Thank you so much, and a great round of applause for all our panelists, and that may many other moments like this happen. Thank you so much. Now we have the picture. I love moderators that keep in time, because we have a counter here with a pump. And I say, if you run out of time, if you do not comply with time, the bomb will explode. Now we'll begin the ending ceremony, and Dr. Augusto Curi will also join us.